Lenny, you have written and you have discussed in our previous videos the indications for BAHA and the technique, and I know that you have some new information now that you want to share with our peers.
The prior discussions focused on the patients who would benefit from the BAHA, and we went through some technical recommendations after having done quite a significant number. Today's discussion is about a subset of patients that I think all of us who are performing BAHA surgery might have some difficulty with. And what I'm referring to is a problem of skin overgrowth at the BAHA implant site. We started to see this when we first started to do the BAHA 4 or 5 years ago. And as time progressed, it became clear that it was much more common in males, especially with very thick scalps. Once we accumulated a large number of patients, we looked at this statistically, and that's really what we discovered. These patients, the males who had a very high body mass index, well over 30, were the ones that we were having more scarring around the implant in the BAHA site. So what we did is we took 88 patients, and we also discovered that out of our patient population, 1/3 of the patient population is obese with a BMI over 30. 1/3 of the population is overweight between 25 and 30, and 1/3 of the population is normal weight. With these parameters, we started to look at which patients had the reactions. Now, of course, we're not talking about the patients who had very minimal reaction, which really doesn't have any significant clinical impact. That would be a hair wrapped around the abutment causing a minor granulation. That might be a very superficial infection. That might be a minor amount of granulation. And these minor reactions were all treated relatively easily in the office. The minor reactions can occur in 20 to 25% of the patients, but they're not of great significance. What we're really referring to in our group of 88 patients was a subset of patients numbering 10 where we had significant scarring issues. And these patients would require repeat excisions in the office or use of Kenalog intradermally, silver nitrate, re-excision, and even a few that I regrafted in the operating room. So when we followed these patients over a long period of time, we found that almost all of them were men. Almost all of them were males whose BMI was over 30. In fact, the average BMI in this group was 34.
Lenny, can you tell us how you calculate the BMI?
There's a standard formula that you can use, and you should use in your BAHA patients. It would be weight in pounds over the height in inches squared times 703. And you or your staff should calculate the BMI, especially in patients who are overweight or obese, by clinical examination. So we did that for these 88 patients. And in addition to the issue of a very high BMI, we think that possibly there's something about the male sweat glands or the male hair follicles that could contribute to increased scarring. There's not very good data on this in the medical literature. There's some suggestion that androgens might cause additional problems with scarring as opposed to estrogens. But what we've decided now clinically to do, and we're revising our paper to publish this in the Journal of Otology, is that when we have a male that has a BMI over 30, they have a 50% chance to have significant skin overgrowth. So we will now place an extended abutment which measures 8.5 millimeters rather than the standard 5.5. And we've done it in 4 or 5 of our problem patients already, and immediately the skin reaction disappears. Now, what's interesting about this development is that even though I saw this several years ago when I contacted the Coco Corporation, they were hesitant to reassure me that we could put the extended abutment on. And after speaking to several of our colleagues around the country, Most had only a very small experience with putting on the extended abutment. Recently, a very interesting article came out in the Journal of Otology from England where they have an experience of close to 1,000 BAHAs, and they have almost 100 patients with the extended BAHA for a long period of time. So this reassured me that we don't have a major issue of excess weight on the extended abutment. So this prompted me to look at this in our practice as well. And so now we have a protocol where we will use the extended abutment in those patients who are male and in those patients whose BMI is over 30. Now regarding the women, whereas the obese males have a 50% chance of having significant skin overgrowth, the women only had about a 13% chance of significant overgrowth. Those women whose BMI was over 30. So there apparently is another factor aside from the scalp thickness and excessive weight, which is probably hormonal. So in the women, we do not routinely put in the extended abutment, although if you would have significant problems, and I do have one young woman who has a developmental problem and she has a huge nape of a neck, and until I put the extended abutment in, she had constant skin overgrowth problems, and now she's been fine for the last 8 months. So in summary, I think you should calculate the BMI when your patients come in the office if they are BAHA candidates. We know the American population is becoming more overweight and obese, and in the BAHA surgical arena, I think it's a factor we have to take into consideration. And do use the extended abutment if you have those males who are over 30 in their BMI. I think it'll save the patient and you quite a bit of aggravation as far as getting the BAHA implant to be free of any significant scar tissue.